All right, welcome everyone. Thank you so much for joining us, and to see you here, and Javier and Tatiana and Andre and George, and of course Ernesto. Ernesto, do you want to start?
Yeah.
It's my pleasure to introduce Ernesto, who's a VR specialist from Belgium, from Brussels, Belgium. Ernesto, please go ahead.
Hi everyone. Thank you very much for this invitation, Ahmed and Gianpaolo. It's a great honor to be here in this meeting. Also, say hi to my friend George, which is there. So I share content screen. So you see the video?
Yes.
Perfect. So this is a case we started with a huge hematoma and a detachment. You see those atrophic holes inferiorly. So before starting the vitrectomy, we put an infusion line in the anterior chamber. And I've been draining since a while with this technique by putting a non-valved trocar in the sclera instead of opening with a knife, the conjunctiva, and then you have to stitch. So we did this opening, and as you see, it was fairly well drained. Then we put in some perfluorocarbon, as you can see, and we approach the detachment quite nicely. So this technique has been, so at the beginning, the retina was quite epic, as you would say.
Yeah.
But we have managed to do a drainage in a safe way. Instead of opening the conjunctiva, you make a cut with a blade, then you drain and you have to stitch. I don't know how you drain these cases yourselves. So I've been draining with this with the valves, and in fact, at the end, it came down as a pretty much straightforward standard vitrectomy for a detachment. You see, there's still some hematoma left, of course, but it was quite smooth. Then, of course, we ended the case with silicone oil because the retina was quite atrophic, and even if you can debate if you put air because there's a tamponade effect, expanding gas effect with the gas, or with oil, which doesn't move. So, but I'd like to hear your comments on this. I'm gonna just end my share so I can see your comments.
I think that's great. So do you drain a choroidal detachment, or you can also drain subretinal fluid with it? Was it a choroidal detachment, right?
Yes,
or a
yes.
Subchoroidal detachment?
Yes, yes. I think was a trauma case with a detachment.
That's great. And George, I think you used the same technique, right? You were telling me that you have a video on a similar case. Was a choroidal detachment drainage?
Yeah, I have a video, but it's a different approach, just because it was secondary to the misdisplacement of the infusion. But the only question that I have, how many days you wait for doing this kind of drainage after the trauma? You go right away, or waiting 2 weeks, 3 weeks? 2 weeks?
2 weeks, because if you do either you do it immediately, then you might have still a blood, but then the eye is very difficult to do surgery. If you wait 2 weeks, we know in the literature that 2 weeks is the time where the blood is quite liquid. In fact, it came out quite fast. At the beginning, we couldn't see the detachment. We saw the detachment just before, but the trauma was 2 weeks before. So we tend to wait 2 weeks before draining any choroidal hematoma in any kind of patient. We wait 2 weeks before the drainage, if we drain. And I always drain with this kind of technique.
That's really very nice. Do you want to move on to your second case, and then maybe George can show his presentation just for the sake of your time? As you are getting your video up, there is a technique that was developed from colleagues in England to use this for suprachoroidal hemorrhage. What they do is they inject suprachoroidal TPA. They inject 0.2 mil of suprachoroidal TPA, and they leave the patient for 4 hours. So like do that at the beginning of the list. And then after that, they do the same technique and it will drain. And the reason is using the TPA to liquefy the blood.
That's a very good technique.
Which I think is a very clever idea.
Shall I start my video?
You cannot see it.
Okay.
Please
you
go
see
ahead
it now? You see it now?
Not as yet, no.
Not yet.
So I go back. Maybe I made a mistake. You see now?
Yes.
Okay, perfect. So epicretinal, this is a complication because we don't want to show always when things go well. Huh? It's we try to show. So this is a case where you see that the problem is in this case that a lot of vitreous, this was a detachment that it failed because there was a lot of vitreous left. This was not my case at the beginning, but so this case was referred to me. And this, unfortunately, I didn't have scissors. So look now, I'm trying to pull. I should have cut with scissors and boom, I make a hole. But it's not the only little mistake I did. So again, I unfortunately ran out of scissors and voila, I was already upset because of this hole. And in my upsetness, I lost a bit of lucidity and my aspiration was too high. And then I ended up with a even bigger hole. So in the epic retinas, we're not always heroes. We're always sometimes also a bit, victims. I have my fellow here who's waiting for the surgery with me to help me. So it's interesting to understand what the home take-home messages in this case is that first, everybody, even in the best hands, are subject to mistakes and complications. Then you have to deal with them. The biggest problem in this case that gave me frustrations, my scissors was out of stock. I just didn't have any scissors. Not 24, not 25, not 27, not 20, no scissors. And so then I tried to do what I could. And unfortunately, the two mistakes I made is one, I didn't lower the aspiration at the lowest possible. So to use the vitrectomy as a cutter, which I should have done. And that created this big hole. Luckily, the patient is doing fine because it was on a nasal side. So she's doing fine, but this is just, we talk about epic surgeries, these things can happen.
It's a great case, and we all go into this really. And I think the important thing is to learn from complications. But as I always say, clever people do not do mistakes twice; they do it more than twice. Okay. Any questions for Dr. Bally?
Sometimes it's very hard to get off with the stick vitreous, and for me, I try to staining with triamcinolone, and I do the same you did. I do bimanual. Young patients, that's really hard. Something that's unbelievable, and I know it's very close to have problems. And even with this hole, we have to work more because you need to clean all these vitreous, and then can take a lot of time and do a good shave of the vitreous base. But it really did a good job because it's hard.
But in fact, this is I think you got the point. In these young patients, I think the surgery is really this. Try to detach the vitreous and really remove and mobilize the vitreous from the retina at the first surgery. Because if you don't do it at the first surgery, then all the inflammation and the time, then you get a huge PVR. This was only 15 days between the first surgery. My second surgery was 15 days after the first surgery. We have a picture, I didn't show it. We have a picture of fundus after the first surgery, and in 2 weeks, she made a huge amount of membranes. And actually, this part of the retina stayed fine. She even did, again, PVR inferiorly after 3 weeks from this surgery. So you really have to remove in young people the most of the vitreous at the beginning. This is why there's a huge debate from doing a buckling or a vitrectomy, because if you do a buckle in young patient, then this kind of difficulty, you avoid it. On the other side, if you do a very good vitrectomy on the first case with a 23 gauge or 25 or even 27 if you manage, we use 25 as a standard technique. Then for the patient, it's way more comfortable a vitrectomy than a buckling. But only if you do a real vitrectomy, a total vitrectomy with a very good shaving and a very good PVD at the beginning. But if you're going to do a half a vitrectomy, then it's better to do a good buccal. But of course, there's the uncomfort of the patient if you have to open the conjunctiva, put the stitches in the sclera, and there's pain, there's mobilization problems, muscles, inflammation, and so on.
We'll have to move on for the sake of time. Ernesto, thank you so much. And
thank you very much. I'm sorry I have to leave you.
No, all the best.
Have a nice meeting and see you soon personally and not just on webs. Bye, guys. Thank you very much.
Bye. Take care.
Bye.
Bye. George, do you want to show your video with the choroidal drainage? And until you load up, we can have Tatiana, do you find anything you can do to help with sticky vitreous as George is loading up his video?
Sorry, can you repeat your question?
No, I'm saying like with sticky vitreous, do you have any trick? Do you use like a pick, for example, or bimanual as well?
Yes, bimanual as well. And I saw the film of Dr. Huning. If you remember his way of doing this movement several times between two instruments.
Yes.
To create some turbulence and special movement for this sticky oil. I haven't tried it.
Right.
Yet.
Thank you. Okay, well, George, yes.
Yeah, this is an old video that I present at the subspecial day at the Academy, and just got this morning. I think it's good for this approach here.
Good morning, everyone. I'd like to tell you about my last year surgery experience. JR is a lawyer from Brazil who suffered vision loss in his left eye after being hit by a tennis ball while on vacation in Miami. Cataract surgery was performed in US. During the surgery, the posterior capsule was ruptured. Endophthalmitis developed post-operatively. After treating with antibiotic injections, he returned to Brazil. On presentation, the visual acuity was light perception. The vitreous opacity prevented the view of the retina. Ultrasound showed the retina detachment. After placing an encyclo 240 band, I inserted a 22-gauge cannula for infusion. I cleared the cataract left behind. The cannula did not completely penetrate the pars plana. It caused a suprachoroidal effusion. I immediately stopped the infusion, but I could not adequately drain the suprachoroidal fluid through the original cannula insertion site. And then I cut down the sclera with a knife and drained the suprachoroidal fluid completely. I complete the rest of the surgery uneventfully with a Pass-Planner vitrectomy injection of PFO, fluid gas exchange, and silicone oil tamponade. JR is now 1 year from the surgery, and after the oil removal has 2100 vision with retina attached. Over the horizon into our eyes. Thank you for your attention.
George, thank you so much. It's a beautiful video. Thank you so much. Right. Javier, do you have any tip on that situation? So I think we heard about checking the infusion for sure in any vitrectomy. I think the classic teaching is to check the infusion, and also, as George said, like don't turn it on when the choroidal detachment unless you're really sure as well. Any other tips for that in choroidal detachments?
Yeah, I mean, and also it's not only that you check the infusion, because it can happen even if the infusion canula slides a bit, and you can have this intraoperatively, so it can happen to all of us. And what I do normally is what Ernesto did in the first case, because if you have these choroidals, you can either try to do what Jorge has done, doing this sclerotomy with a blade and draining directly, or also use a non-valve infusion, a non-valve port. So normally what I do is to use a port to try to drain the detachment and carry on as he has done.
That's beautiful. Okay, George, are you okay? We're gonna go leave your second case for now and go like with this order: Tatiana, then Andre, then Javier, each a case, and then come back to make sure we have good
just
okay.
Only one last tip.
Yes.
This case was a trauma case, and we have to really careful patients that has a trauma in a short period. We have some pathology in the vitreous base, and maybe it's more easy to get through the suprachoroidal space. And I agree with you that the first thing to do is try to drain through the same trocar. You don't need to cut the sclera, and you need to remove the infusion for another trocar and try to drain this, and then you're gonna be good. But you need to do this in order to finish the surgery. That's become impossible to
That's a great tip. Tatiana, do you want to load your PVR video? We can continue to speak about detachments. You have a PVR video?
Yeah.
I think one tip as well, when you have a choroidal detachment, as Tatiana is loading up her video, is not to go towards the mid-vitreous cavity, but go towards more the ciliary body. So go like this way rather than this way. I find that helpful as well.
Can you see my screen?
Yes.
Yep.
Thank you. First of all, I would like also to thank you for your invitation. It's a great pleasure to be tonight here with you. And I tried to find something to match the title, Epic Surgery, so I presented to the public. And my first case is about a young man. He is autistic. He was brought by his mother and sister. They saw the white pupil, and he had mature cataract and almost closed funnel retinal detachment. So first surgery was performed, and I started after the trocar insertion with phaco and IOL implantation. And then I saw the closed funnel.
We cannot see the video yet.
Yeah, and
okay.
First I created the window to the entry to
Tatiana, we see only the slides, but we cannot see the video. Is that?
Sorry?
Yeah, we cannot see the video running. We can see only the slides.
Oh.
We can put it in presentation mode.
Oh.
Yeah.
Yes.
Okay.
If you can make it like full screen, if possible. I mean, we can see it well. You can make it full screen.
Can you see?
That's perfect. Yeah, it's coming up, I think.
Is it okay now?
No, it's black screen.
Black screen. So maybe I
maybe if you can do it like it was, not full screen, okay. We actually could see we see a good view now.
Can I see like this? Can I show like this?
Yes, yes, we can see it very well.
Okay, Faker was done, and you can see the panel retinal detachment. And I created an entry and started to clean the surface of the retina with peeling, with removing epiretinal bands with forceps bimanually. You can see dialysis. So obviously the patient, there was blunt trauma, and we can see subretinal clots, and I aspirated it as well. Clean the retina and put PFCL and started to continue the 316 degrees retinotomy. I don't like the relaxing retinotomy, but it was the best decision in this situation. And due to necessity of next surgery, there was no any laser, and here is the picture of. Can you see like this picture?
We saw it and it went away, but we saw it. So you did not laser around it; you just left it under oil, right?
Yes. Not to stimulate the proliferation, and it's the situation after 2 months, and we made second surgery because I was sure that this surgery will occur, and the surface was clean again. Epiretinal tissue I tried to remove as much as possible. This edge was root, so I cleaned it and cleaned subretinal space. There was tissue and some PFCL bubble. Almost complete PFCL tamponade, and try to turn the retina into almost right position. After that, applied laser coagulation, put silicone oil, and 2 years have already passed. He's still with silicone oil. His visual acuity is counting fingers. He's satisfied. So this is my first case.
So it's a very good case, very difficult, really. So Andrew, would you ever consider not lasering the retinectomy edge? Because actually there was some thoughts that the laser causes more contraction of the retina. So maybe if it's under oil, actually don't laser it and laser it back if the retina attaches. So that there was some thoughts from the Netherlands read to do that, not laser. What's your take on this?
I think, sorry for my voice, I had a cold. I think it's a very nice approach. Sometimes I also do the same way, because really during the second operation, we have not only proliferation, but atrophy of pigment epithelium after laser, unsuccessful laser. This is a more problem. That's why I agree with Tatiana. It's a good way, good idea not to perform simultaneously with the first surgery. Remove completely as much as possible epiretinal, subretinal membrane. But it's very difficult. For me, reproliferation in such cases it's maybe about 100%. It's very difficult cases, but with very nice success. My congratulations.
Anyone has experience with methotrexate injection?
No.
After I did some case, looks good. I'm waiting for the trial that is going to be published maybe this year. But in my clinical view, they helps in this bad case of PVR that we reprobation frequently. And then I'm still using methotrexate after all this kind of surgery.
Javier, you have a case on PVR, right? Do you want to load that up? So it's going
yes,
with the same session.
Sorry.
And then we'll get back to you, Tatiana. Is that okay? And then we'll go Andy. Then we go another round.
Okay.
So I have Gianpaolo on the phone. Just 1 second, as you, Gianpaolo, hi.
Hi.
Yes.
Can you see the slides?
Can you join the link? They send it.
Can I start or? Can you see the slides or?
Yes, we can see.
Okay. So,
yes, I can tell you my link as well. I'll send it to you now.
Okay, so I'm gonna be showing a case of subretinal PVR. We look at the classification from the Ryan's retina.
Yeah, let me send you the.
What we are seeing is that subretinal strand is a severe form of PVR, and this is the definition of how it's going to be around the disc. So this is exactly what I'm going to show. This is a patient that had a cataract surgery, a complicated cataract surgery in a different hospital, and he's referred to as a phakic with iris incarceration in the main incision. The first thing is to close the wound. And then when we look at the back of the eye, you can see 2 areas of choroidal detachments and a retinal detachment because of probably hypotony that he has had after the complication. The surgery was done like 3 days before this. Then what we do is to put PFCL to settle a bit the back of the eye. Then we try to trim the vitreous base, to try to do a gentle vitrectomy. Carefully, you can see the demarcation lines of the detachment that we have had in this eye. And then what we want to do is to get rid of all the vitreous peripherally. There is a bit of also epiretinal PVR over there. This is the typical black cords that you can see there. Then we do, and there is a subretinal strand that you can see there. We do an access with the diathermy, we do an access retinotomy, and then we grab the subretinal band with the forceps. This is 23G at that moment. Now we are using 25 for almost everything. And what I like to do in these cases is to grab the subretinal band and then use a second forceps like a spaghetti maneuver to try to avoid traction over the edges of the retinotomy. Normally, if you do this, normally this allows to pull from the subretinal band without enlarging the main access retinotomy. Sometimes it's not easy because it's quite attached. So like in this case, what they have done is to grab the subretinal band that I have nearly removed with the first hand, swap hands, pull from the left forceps, and then use the right one to go to the attachment of the subretinal band, in the inferior part of the retina, in the RPE. And it's quite nice that when you get rid of this traction and you release this attachment, automatically the retina gets back to his original site. This is possible because the complication was relatively fresh, because this surgery was done 3 days after the original one, the complicated phaco surgery. And now it's like dealing with a standard attachment. Once we have removed the subretinal band and we have done a careful peripheral shaving of the vitreous base, then I put some PFCL to flatten all the rest of the retina, and little by little we can see how the subretinal fluid comes through the retinotomy. I try to absorb all the fluid from this small hole. I do an FAX, a fluid air exchange, to try to flatten the peripheral part of the retina. Then I do complete drain as much as I can. And then once the retina is flat on back to its area, I do a laser retinopexy to the small hole. This is like a standard attachment, so it's not tricky from this side. And this is what I do normally with the back flush. I do this removal of the ports. In this case, I left the patient a phakic, and there's something you need to watch with this eyes. Normally I don't do an iridotomy. In this case, I did it at 6 o'clock, and then 6 months later, I put a Carlevale lens. The patient came back to about, it was like 20/60, something like this. And that's the case that I wanted to show. So I don't know if you have any thoughts on this.
Javier, thank you so much. Difficult case. You did fantastic. That's great. Did you put oil in the eye, right, the first case, or you left it gas filled?
Yeah, I put oil. So I did just this complete drain, and once the eye was filled with air, then I put oil.
And then you came back and you took the oil out. And
exactly. That's it.
Okay, any comments on Javier's? Yeah.
The subretinal bands is very hard to pull off. Sometimes your maneuver is brilliant to just hold the retina and try, because sometimes when we are pulling, the retinectomy become large and it's terrible. But sometimes in the peripheral bands, we don't need to pull off, just leave it there. We can fix well, but you did great. Very good job.
Yeah. Yes, well, the first time when I saw the band, it was like, wait, if you manage to flatten the retina, then you can leave it. I mean, as you said, if it's not threatening the macula, then sometimes you can leave it. But in this case, since the band was so thick and was around and surrounding the optic nerve, at that moment when the retina was detached, I think, well, it's better to do a tiny hole, then get rid of it and make sure that the retina is flattened and relaxed. But I agree that if it's peripheral, sometimes you can leave it.
One good tip to make sure if you need to remove or not, just go for air. When you go for air, we can notice if it's traction and the retina is not attached and we need to remove or not. But when it's necessary, you did good.
Yeah, thanks a lot.
Javier. Hello, everybody. Sorry for the delay. I apologize. I just finished theater. There was an emergency at a trauma 22-year-old that fell on a window and cut his eye open. I did see your procedure. Very, very nice. What impressed me, besides all else, is the control that you seem to have with that chandelier. Any tricks that you can tell us about? Because generally, a chandelier tends to move about, and it's not easy to have that good of a lighting. So what that was a single chandelier you had in, not. So
and actually,
was it, can we say the name of the brand? Is it
this
one of the Alcon?
It's funny because this is not the one that I'm using now.
All right,
but this was a I think this was a Synergetics one, a torpedo one. And now I'm using the standard Alcon system, the 25G standard chandelier, and I really love it. I really love it because what happens with some chandeliers is that sometimes during the surgery, it really is, I mean, sometimes you lose it. And then you have to put it again, and it's kind of a nightmare, especially if it's a complex case. This one and the one by Alcon now is quite good because then you can direct it. It has this metal, like a metal band, so you can bend it and point the light towards where you want to work. In this case, I put it to the posterior pole, and it was quite nice because if you're going to do bimanual maneuvers, this is really helpful, and it gives you a really good light.
Javier, sorry, I need to interrupt you for 1 second. Andy, would you be kind to load up your case? Any case you choose, the macular hole or whatever case you choose, Andy, Henry? Dr. Rubin, do you want to load up your case? Share your case. You're muted.
I'm unmuted.
Just for the sake of time.
Which case? I have two.
Yes, can you? I think both of them are not detachments. So if you want to start with for example, the macular hole one.
Okay. Okay.
Yes. I'm sorry, Javier, if you want to finish, you like the Alcon one you were saying, right?
Yeah, no, I mean, I've tried most of them, but this one is the one that I'm using now, and I'm quite happy.
Excellent.
Thank you. Thank you.
Did you see?
Yes.
Yes. My case is a combination techniques of inverted ILM flap technique and subretinal fluid application for treatment very large traumatic full thickness macular hole. It's a man, 52 years old, suffered 6 months from a blunt injury, BCVA 0.1, central scotoma, metamorphopsia, and full thickness macular hole, 1,142 microns. First of all, was performed vitrectomy. Posterior hyaloid was elevated and excited to the equator. Peripheral vitrectomy was done, also using additional illumination. ILM flap was preparing on 360 degrees around the hole. Then subretinal BCS injection was performed in 3-point manner. Then I tried to induce centripetal subretinal fluid displacement to macular hole, but unfortunately we see zone of strong retinal adhesion. That's why we decided to perform dissection. First of all, with tip and then loop. Because for my opinion, it's a very important approach that to induce the maximal retinal mobility of the macular hole size, age. It's not so easy because in trauma, this adhesion, it's very severe and very taut. But after removal adhesion, retina was mobile. And after that, we covered the hole with ILM, circular flap, fluid exchange with the position of the hole edges. And ILM flap position correction. And silicone oil. 1 week, we saw a decrease in size macular hole, but so-called flap closed. But in a month, we see complete closure. It may be not a primary intention, but secondary, because it's a very severe defect. And vision a little bit improved, not so significantly. On microperimetry, we saw a reduction in central scotoma and improved fixation plot. A retinotomicide after surgery was seen only on autofluorescent images.
Yeah, it's a difficult case. Anyone has a quick comment? I think we need to move quicker with the second round for the sake of time. Any quick comment?
A very quick question. Why did you use the PFCL?
I used PFCL to prevent fluid from premature escaping through the macular hole. It's not my idea. I don't like to do it, but it's idea Klaus Klar and Myers also use it. Idea that it's necessary to collect more liquid before it's entering through the macular hole, not to leave in it. But in such cases, it was absolutely unnecessary to use PSL. You are absolutely agree.
Because you removed it before you actually got the detachment.
I removed, yes.
Okay, yeah. Thank you.
Andy, could you stop share? And George, could you kindly share your next case? Could you please, then we'll try to come back to you for the second case, Henry.
My second case.
I think we'll go for George to have a second round.
Okay. Sorry.
Back to you. No, not at all. I think we'll just move a little bit quicker. Fortunately, they gave us only 1 hour, which is not enough. Because the beauty is in the discussion.
Sorry, I need to come back. Yes, thank you very much to invite me to join such a great team of vitreoretinal surgeon. And this case of, again, of funnel retinal detachment, a 42 years old female pseudophakic with 6 months retinal detachment, LP. And this is the surgery. I just start with the posterior pole, remove all the scar, the PVR, and the membranes. After I get a good view of the optic nerve, I just inject some heavy liquid to stabilize the retina and spend a lot of time doing all this peeling. Try to clean the retina, epiretina, subretina. But sometimes, after we peel everything, we just realize that we have the shortness of the retina in the periphery.
Sorry, George, we may have lost you the connection.
And we need to...
Okay.
I think we lost.
That's something that we need to do when you have so bad case. But one thing that I have to mention, after doing this, it's very important to clean and depress all the periphery and trimming all the retina left behind, because this retina left behind can make a scar and pull off the ciliary body, and we have ptesis after 6 months. And then something that's we have to notice. And after 6 months, she has confingered 2 meters. That's it.
Well, thank you. Tatiana, can you load up your case? And we have a question to George as you're loading up your case. Any questions to George about this case? He made a great point about removing the anterior rim to avoid rubiosis and phthisis.
Do you do anything else on the ciliary body to prevent phthisis?
No, just try to clean as much as I can. This I think the most important thing is clean and depress and cut all the retina. All the retina can become a really serious scar tissue and pull off the ciliary body and become atrophic eye. This is the thing that I'm doing right now.
Okay.
Tatiana, can you load your case?
We have a question.
We have to move on with the cases because of time. Can you share the case? Share your second case, Tatiana?
Yes.
Please, thank you.
And again, I will show you in small screen. My second case is about young woman. She is 30-year-old and she had tractional retinal detachment within several months. She was afraid to operate this eye because of unsuccessful surgery before. You can see her another eye. She had a lack of visual acuity, and there was silicone tamponade and band keratopathy and cataract. So she finally she decided to operate, and here is her first surgery. It was lens-sparing surgery. Vitrectomy of old vitreous hemorrhage was performed. You can see atrophic ischemic retina. Almost all vessels are obliterated and white, no red vessels. First, the delamination was done, and I tried to separate this tissue without a PFCL, but after some maneuvers, I decided to put PFCL. And again, I removed it and tried to clean the surface from with 2 hands bimanually. Again and again, clean the surface of the retina. And there was subretinal band. I performed punctual retinotomy and started to remove this band, but the retina was strongly stretched, so I put silicone oil, and with 2 forceps, like Javier showed, I removed this band and finished through the air fluid exchange. Applied some laser only around the hole. I put the silicone oil, and after 2 months, I performed second surgery. Relax the retina and try to remove the remnants of proliferative tissue, ILM peeling, and applied laser. This young woman has visual acuity now 0.1. She's happy, and she was being able to see her 6-year-old son, and it's happiness for the surgeon as well. Thank you.
Thank you, that's great. Javier, can you load up your diabetic case, and we can have a question to Tatiana as you're doing that, please? You can share screen. Any questions to Tatiana about her case? I have a quick one.
Yeah.
So there were no tears. Did you feel that you could leave the band because there were no tears and just leave the band, or you thought it actually you had to remove that? That's my question.
If there were no tears.
Because you did not have any tears, right?
Yes,
it
yes.
was only traction.
It's a question. Yeah, really, it's of course I decided to remove any proliferative tissue, and I was not sure that the retina will attach if I didn't remove this band. But the question is if it's my question. If the retina is, if you don't create any tear and you have this mobile retinal detachment, would you perform the retinotomy and drainage of subretinal fluid?
For me, I would leave alone. I would leave alone and leave gas or air. That's me.
I would not remove the band, really. No.
I agree.
I think it was risky, but you did a very good job. But
yes, it's beautiful risky. And beautiful outcome. Javier, back to you. Yeah, sorry.
You're very brave. You're very brave.
do you use in such cases anti-VEGF therapy in such atrophic and avascular retina previously, before surgery?
Tatiana, can we have a quick answer on this? No. Okay.
Okay, thank you.
Here we're so you're racing with time. Go ahead. Go ahead to the video.
Can you see the slides, right?
Yes.
Yeah. Okay. So this is a 64-year-old man that comes from casualty with no previous medical history and metamorphopsia in both eyes. The vision are 20/50, 20/80, and rubeosis in both eyes. And this is the fundus. So the patient was not aware that he was diabetic. And so this can happen. And this is the image of the left eye. You can see all the new vessels sprouting. This is the OCTA montage. You can see how nicely the new vessels are seen here. This is the structural scan, and this is the surgery. So the case is not particularly difficult. There were some areas of traction and some small tractional retinal detachment. But what we did here was to do a bimanual surgery again with a chandelier light. And in this case, the special care that we need to take is to make sure that we are not pulling from the retina. So this is how with the hyalid was removed with these gentle maneuvers with both hands. As curved scissors are used to cut and delaminate these small areas of traction. In some of these areas, the retina was lifted. There were some small detachments over there. So as Tatiana showed just now, I mean, what we have to do is try to do it as gently as possible, so we don't make any breaks. And this is the only care that we have to do. So I'm just doing this very, very slowly, just to make sure that I'm releasing the attachment points and doing it little by little in all the arcades. Some of the areas are easy to reach with the left hand, so we need to swap hands to make sure that we are getting the best cleavage plane. I like this image because you can see that the new vessels are literally removed from the retina. So we try to shave and remove all these attachments. Sometimes I use the scissors as a blunt tool, so not necessarily cutting. If we can manage to delaminate the hyalid, sometimes you can lift it without doing a cut. In this case, as we just mentioned, I put an anti-VEGF 4 days before the surgery to try to reduce the intraoperative bleeding. But even if with these drugs, you still can have some bleedings, I try to remove all this blood with the back flush, a passive aspiration back flush. And then I try to trim all this hyalid. Once I have cleaned the posterior pole, I try to extend it further to the far periphery. And once I have lifted all this, then I do a complete shaving of all the vitreous as much as I can. So I like to do the vitrectomies as wide as possible. And also I like to indent the far periphery to try to make sure that the shaving is as extensive as possible. I also like to peel the ILM in these cases. I think it's the only way of making sure that you are removing all the remnants of the posterior hyaloid. So I always try to peel with brilliant blue to try to remove all this. And once I have removed all the attachments, I do this laser, a complete 360 PRP up to pars plana with indentation. In this case, I did an SF6 tamponade. For the sake of time, I think I'm gonna move forward from this. And the pretty view is this is the postoperative fundus picture, and this is the postoperative wide field of CTA montage. And it's quite nice if you can see how with the surgery you have literally removed all these new vessels. In the inferior arcade is quite nicely, and you see all these dropout areas in the far periphery. And this is the second case that I wanted to share with you all. This is the structural scan, but this is mainly all that I wanted to share.
It's beautiful, Javier. Beautiful montage. Andrew, can you please share your video? Can we share your last video, Andrew? Yes, that's great. I'm sorry, we're racing for the sake of time. If we have a couple of minutes, we may ask you a question, Javier, but this is so beautiful. Andrew, please.
I don't hear you.
You might be muted. Henry, we cannot hear you.
Yes, yes, yeah, sorry,
okay,
sorry,
we can hear
it's
you
my
now.
fault. Yeah, you hear me? Yeah. You hear me?
Yeah, yes.
Yes.
Yes, it's a female, 32 years of old, also with blunt trauma, 3 weeks ago, BCVA 0.5, central scotoma, metamorphopsia. OCT reveal subretinal blood, subfoveal clot, and disorganization of outer retinal layer. We use classification proposed by Sylvia Bob. It's I like this classification because it's Mosen classification as a system of support decision. And according to this classification system, our case was described as F1L1, A2, T1, POS1. That means that blood dislocation may be ineffective because much time. We should consider the indication for surgery, but with guarded function prognosis. We decided to remove clot. After posterior vitreous cortex removal, a non-penetrative technique, subretinal BSS injection through the area with local ILM removal was used as proposed by Akanuchi. Then retinotomy was performed with scissors. Unfortunately, after subretinal blood washing out, I was unable to mobilize the subfoveal clot. It was very rigid. Further attempts to safe insert forceps into the subretinal space were also unsuccessful. Based on this, I changed my surgical plan, and subretinal sodium hyaluronate was injected to create and maintain subretinal space for safe surgical maneuvers and to protect the photoreceptors. And after that, subfoveal clot was been safely extracted with forceps. ALM peeling up to retinotomy was performed to release possible post-op traction. Elimination of such traction on the edge of retinotomy make it possible not to use laser retinopexy. Then subretinal hyaluronate was removed as complete as possible. Fluid air exchange and SF6. A 2-week post-op, OCT revealed complete removal subretinal clot, but residual amount of viscoelastic. At 3 months, viscoelastic was completely disappear. Interesting site of retinotomy. At 3 months, we see only small point or small defect, but at 6 months, it was closed completely. And we see, unfortunately, on autofluorescent image, some atrophy pigment epithelium in place of one of retinotomy. Unfortunately, at 9 months, choroidal neovascularization was detected with decrease of vision after aflibercept injection. Process was stable, but with decrease some vision. Thank you.
It's very interesting dissection, Henry. I think we can actually spend more minutes. They said there were probably the last session, so we can spend a few more minutes if you all have time for discussion. We can discuss Andrew case. Any questions on this case? It's beautiful. I mean, I like the visco dissection. The problem is removal can be traumatic, but I think it's a catch-22 really. What would you do otherwise? So any comments on?
Yeah, beautiful surgery. Thank you, Andrea. Was it trauma case? Or it was
yes.
Oh.
Yes, it's trauma case. It's trauma by K.
Yeah.
It's trauma case. I asked Ferenc Kuhn about this case, and he suggested a little bit to wait and check neurosclerosation. It's my fault. I think if I can repeat my procedure, I injected anti-VEGF early, as maybe as protective, and Kuhn absolutely was correct.
And this is not the standard macular hemorrhage, of course, but what about trying maybe some subretinal RTPA to try to mobilize all this clot? I don't know if it may work. I mean, it's not the normal case, but
yes, maybe. First of all, it's 3 weeks, and also biggest part of experts suggest that it's not a window possibility. 3 weeks. The second question, in Ukraine, it was a problem with Altiplaza, and we haven't TPA.
Okay.
Gianpaolo, any final points or?
No, I just want to ask Javier, what system do you use? What viewing system? Was that a Resight that you're using? Okay.
Yeah.
Okay, thank you.
I have here a very nice dissection of the diabetic delamination. It's I think the point is starting from the center to the periphery makes the delamination easier, in my experience as well.
I mean, the delamination was not as particularly difficult, but there were some areas where you had some small tractional detachments, and I was very cautious because I didn't want to make any breaks. So I was really slow and it came out nicely.
I think what you showed very well is that you actually should be using the posterior hyaloid to help you as a cleavage plane. So you actually showed that very, very well because you didn't remove any of it until the very end. So it was perfectly clear that you're using that as a cleavage plane, and I think that's something to learn from. Absolutely, yeah.
Thank you.
How was your intraocular pressure?
In my case, I mean, it was a standard. I didn't, if I had bleeding, sometimes I like to put the pressure high, but in this case, I mean, the bleedings were not that much, not that evident. There were small pinpoint bleedings. I put anti-VEGF 4 days before to make sure that we didn't have massive bleedings. But even with this drug, with this anti-VEGF, the patient was still bleeding a little bit. So I don't remember if I had to put the pressure really high at some points, but I don't remember that dramatically. So probably I didn't have to do it.
How many days you inject the anti-VEGF previously?
Normally, I like to do it 4 days. I don't want to do it earlier or later because I know that if you do the surgery shorter than 4 days, the effect is not completely there. I mean, you can have reduced bleeding, but the maximum reduction in bleeding is about 3-4 days. But if you go beyond this 4-day threshold, then you start to have the fibrotic switch. So then you can make traction worse. And normally I try to do it. It's not always possible because of management reasons. But if I can do it, I like to do it 4 days before the surgery.
Tatiana, you had a very difficult case because you were dealing with a very atrophic retina. And interestingly enough, you actually lasered, you did a PRP after the second surgery. Is there any special reason why you chose that?
There was a lot of bleeding, remnants of blood clots after first surgery. So I decided to wait and do it in maybe between the surgeries, but I decided to do it in second surgery. Usually I do it during first surgery, of course.
Do you use anti-VEGF in the interim? Because I had a situation before. What I did is I used anti-VEGF in the interim because it cleared after like 2 months. Would you consider that, or?
I did not see the retina due to hemorrhage. And there was tractional retinal detachment. Usually we try to inject anti-VEGF 3 days, 2-3 days before, but not in this case.
What about you, George? How many days you inject beforehand, before the diabetic cases? 3 to 4 days as well?
I think 3 or 4 days is standard, but sometimes I can wait 7 days when I have too much blood tissue, new vessels, and I try to wait more. And sometimes with very bad case, I have to go up to 50, 60 millimeters pressure for 1 minute to stop bleeding. Sometimes it's pretty hard to operate diabetic case. I have a bunch of this, and the key point that I mentioned is try to not have any break, any hole, because if you have, maybe you lost the case. The second thing, if you do a beautiful job like Tatiana did, I just sometimes put only air and waiting for the fluid underneath to go by themselves, and sometimes just laser at the office. We don't need to laser during the surgery if you have too much fluids, but just follow very close. And sometimes at the end of the surgery, I inject again anti-VEGF just to stabilize this bad case if you don't have opportunity to laser all. But very beautiful case, very tough case. When you have such ischemic retina, the retina is very, very fragile. We can make holes in a second. And this is the point, not make holes.
That's a great conclusion.
Would you leave the band, subretinal band? Would you leave?
If you have removed it.
Sometimes we leave, because sometimes if you make a big hole to remove this, you're going to destroy everything. The retina, ischemic retina, is something that's almost dead. If you do anything, you can lose the eye. And it's hard decision. It's very hard decision. Not easy.
If the retina is really, really necrotic, normally, if I can, I try to do a retinectomy, because I think it's better not to have this retina than having this retina with this ability of contraction. So if I have really ischemic retina, like in the Tatiana's case, if I cannot manage to flatten it and put it back in place, sometimes I even rather if there is a minimum traction, I'd rather cut it than leave it over there.
The problem is you go.
This is controversial.
The problem is now you go into PVR, and in addition to this PVR.
Yes.
And the problem is most of these cases, I don't know, in my, at least one I saw, they tend to re-detach and the retinectomy edges roll. So I don't know. I always thought it's best to treat these patients like ROP, just do the minimum and don't create breaks and finish. But it's a very interesting topic.
Yes, yeah. I don't think that cutting these retinas is the best option. I've always had very bad experiences, like Hamid. They generally roll up, and they can become really very difficult to put back into place. I'd rather leave some amount of traction and a shallow detachment rather than to go into the perils of doing a retinotomy. But then every single case is different, isn't it? So my question was, do you feel that you always need to put silicone oil in? And George has addressed that question already. Do you always put silicone oil? If you don't have any breaks, even in cases which are particularly challenging, but you've finished your case, you have no retinal breaks, do you feel that you always have to tamponade with oil?
With air, yes. Our routine approach with air. I noticed that rebleeding is a cure if we had new vascularization near the optic nerve. Maybe in these cases to prevent rebleeding in post-op period. But almost always we try to finish with air. But this patient was a young woman.
No, but this is different, of course.
Yeah.
What about
with
all of you?
Do
you finish with AM, some of you, or BSS, or what? How do you top off your?
I try not BSS, because it's hypotony, a very high level hypotony post-operative period. If surgery without complication, without tears, with traction, is really air. But it depends also of status of patients and the status of lateral eyes. Unfortunately, in Ukraine, so many patients are unstable with diabetic. That's why high risk of rebleeding, and it's also a problem. That's why sometimes it's more effectively to use silicone, and after that to remove. But it's a good practice. It's a standard, of course. It's air for me.
Okay, so just a thought. I many times you have rebleeds for a number of reasons, and you would like to have the retina dry, because obviously if that's the case, you don't get rebleeds. So I've started using in the last few years short-acting gas that will last longer than air and will give you a chance for less rebleeds. It's just an idea if you want to try that. It's SF6 works. It's cheap and it works very well.
I agree with
for me. Sorry, go ahead, Javier. Go ahead.
No, I agree with it. I'm not that brave to leave air, and I'm more comfortable putting SF6, just because it gives you this extra bit of days with tamponade.
Also, you use SF6 too. Good. Okay.
In my hands, I use either SF6, or if for whatever reason I'm not happy to leave gas, then I go to oil.
Okay, I agree.
And I don't use oil in diabetics. I think it's the only indication I use oil in diabetics is a situation I try to avoid, where I have tears and unrelieved traction on them. And that's the situation I always tell myself I should have avoided by not tackling this area. I mean, the main aim for me is to treat the macular area, and everything else is a bonus. And if I can treat it, fine. Otherwise, if it's too much, I will leave it. I just try to treat them as ROP. I also think, in my view, oil does not decrease rebleeding. On the contrary, you get the blood under the oil and it forms a clot, and it's very difficult to remove. So I always leave air. I use air or gas, and very rarely would use oil. And in these cases, it's oil for life, and a situation I try to avoid.
George, you agree? Yes.
Yeah, I agree. I think the oil is just on compartmentation of the eye. The blood is gonna be set down, and if you need to remove fast, it's gonna be a big scar, and it's terrible. Yeah. And I agree with you that SF6 is a good option too. It's case by case. I prefer air only if you have sure that I did any breaks, any damage in the retina. But SF6 is work pretty much good. I agree, definitely.
Andrei, do you have anything to add to this? Andrei, anything to add? Unmute.
Yeah. Maybe no, I haven't any comments. No.
I think these are really fantastic cases, and I would say really epic surgery. And we're also very lucky because we're the last session, so they let us really run more. So that's fantastic. And Gianpaolo seemed to have also an epic day with trauma, which is good, because I had a drop nucleus as well from one of our residents here, so I came just in time.
Yeah.
Gianpaolo,
Okay.
would you like to conclude the session?
I would like again to apologize. Unfortunately, we have theater, as they call it in England, or operating room on a Friday, and it should end at 5 o'clock, but it did not. So we carried on with this trauma case, which was very, very challenging. This is a 22-year-old construction worker that fell on a window frame and basically has a very serious open globe injury, which I have done primary repair on. I presume that I will be going back on Monday or Tuesday to release this retina, which is certainly incarcerated in the scleral rupture. But so apologies again. I think from what I got at this session, it was extremely interesting because of obviously the quality of the surgeons, but also because of the diversity of the cases which were presented, which are really nice. And finally, because we were able to focus on a few practical issues that we tend to forget when we see the beauty of certain procedures. We tend to ask the simple questions like, the one we just discussed? Because when I talk to colleagues, they all leave silicone oil. And I say, no, I don't agree with that. I don't think you should be using silicone oil. So having the opportunity to have more opinions from, world-leading surgeons like you all are, is certainly very helpful for whoever is watching us and really wants to know the everyday details of what to do in their practice. So I think this was very useful, and I thank you all for being here. Hamid, thank you for organizing this as usual. You are outstanding, and I know you're working, and we really do appreciate that you give us your time, and you're probably going to go back to your operating room now. And I wish you all a very good weekend. Okay.
Thank you so much. Thank you so much, all, George, Tatiana, Andre.
Thank you.
Thank you
so much.
Thank you.
Stay safe. See you soon. Thank you.
Bye-bye.
Take care. Bye-bye.